Hello, my name is Melissa Watts, and today I'll be presenting to you my research proposal for the subject Research, Theory and Methodology, which is part of the JCU Masters of Nursing, specialising in critical care, assessment number 3. Fluid overload is a common problem for patients with congestive cardiac failure, resulting in frequent and lengthy hospital admissions. Nursing staff from a cardiac ward in Logan Hospital have introduced a new blue fluid restriction jug to help control the amount of fluid the patient receives daily. Nursing staff at this hospital want to evaluate the effectiveness of the new fluid restriction jugs in regards to decreasing the incidence of fluid overload in patients with congestive cardiac failure. If the jugs prove to be successful, then consideration of implementation of these jugs into other wards, hospitals, or even patient homes eventually. If the jugs prove to be unsuccessful, then further education of the patients, family, catering staff, and nursing staff will need to be considered. So my research question today is, in patients with congestive cardiac failure, has the implementation of blue fluid restriction jugs decreased the incidence of fluid overload? A background search was conducted across multiple databases, including CINAHL, the Cochrane Review, and PubMed. The exclusion criteria consisted of non-English written articles, in which 2 articles were excluded. The inclusion criteria consisted of articles which focused mainly on the effects of fluid restrictions in congestive cardiac failure patients. Altogether, 376 articles were found relating to the search terms congestive cardiac failure, heart failure, and fluid restrictions. Only 22 of these 376 were relevant. The research that had been done showed that did not specifically investigate blue fluid restriction jugs. The research that had been done was done on quality of life of congestive cardiac failure patients who were on a fluid restriction, compliance of fluid restrictions, or having a fluid restriction versus not having a fluid restriction, in which all of these studies found that there was no difference in the quality of life or in fluid overload. Specifically, one article done by Travers studied a similar concept of fluid restriction in the management of decompensated heart failure. The study consisted of 34 participants in a hospital setting. This article suggests that fluid restrictions may have been of benefit, however, the majority of the participants were managed with IV diuretics, in which they responded to promptly. Therefore, this study may not have reflected a true result. This needs further consideration, as some patients do fail to respond to diuretics. So the problem is that fluid overload has been an ongoing problem in patients suffering from congestive cardiac failure as they become extremely short of breath or become adenitis. The problem in regards to nursing is that the patient's length of stay increases. The patients become anxious, and because they can't breathe, and the rate of readmissions increases, and the patient could potentially develop acute pulmonary edema or APO. The biggest issue around this topic is patient education. I think if patients are aware of their condition, what the complications of the conditions are, and how to either prevent or manage the complications, then the hospital admissions or readmissions should decrease. I personally think it's necessary to conduct this research specifically on the newly implemented blue fluid restriction jugs to determine if they are effective in controlling the fluid overload in hospitalized congestive cardiac failure patients. I noticed that the catering staff on this ward specifically would give the congestive cardiac failure patients full cups of their drinks at morning tea, lunch, afternoon tea, supper. Usually the patients with heart failure, we give them half cups so they don't exceed their fluid restriction. Or I noticed also that family members would come in and top up their jugs in the sink, which would also exceed their fluid restriction. This is potentially causing the patients to exceed their fluid restrictions, as I said, and then gain weight. And then following that, they become edematous, short of breath, and go into APO. These new fluid restriction jugs are pretty much identical to the normal jugs, but they are coloured blue instead of clear, so that the catering staff can recognise that, hang on, these patients are on a fluid restriction. I can't touch these jugs as they get topped up every midnight. And it also makes them realise that they only are allowed to have half a cup of drink. So these jugs here are the normal jugs, which are clear in colour, and these jugs over here are blue. I'm not sure if you can see that very well. So the blue ones are really easy to identify. A plan was developed as to how much water should be allowed in the jugs for depending on what fluid restriction that they are on. So this is a big sign that we have on the ward. So most patients are on a 1.5 litre fluid restriction, in which they're allowed to have 500 mils into the blue jug at midnight, and that's what they can have for the 24-hour period. If they're on a 1.2 litre fluid restriction, they're only allowed 300 mils in the jug. And for renal patients or severe heart failure patients that are on an 800 ml fluid restriction, they're not allowed any water in the jug. However, the jug does stay there so that they can still recognise that this patient is on a fluid restriction. These amounts have factored in morning tea, afternoon tea, and supper drinks as well. So the research aim. This is going to be a quantitative in-depth study that aims to assess the participants' fluid balance charts to determine if the fluid restrictions have been adhered to with the implementation of new fluid restriction jugs. Specifically, this study will compare the data from fluid balance charts against daily weight statistics, as well as factoring in the doctor's rounds in the morning to see, the doctors do an examination of their chest, listen to their lungs, which you can often hear crackles or wheezes if they're beginning to be fluid overloaded, results from chest x-rays, and just the general impression of the doctor's round in the morning, usually if they think they're dehydrated or over-diarized, or overloaded. This will determine if the participants are losing, gaining, or at a stable weight. The methodology I'm going to use is evaluation research. Trocum defines evaluation research as a systematic acquisition and assessment of information to provide useful feedback about some object. This approach is really relevant to the proposed study, as the aim is to learn if the blue fluid restriction jugs have accomplished its intended objective. For this study, a summative evaluation will take place, as this will look at the final outcome of the jugs rather than an ongoing evaluation or continuous evaluation. The evaluation research is a beneficial approach as it is cost effective for the researcher and is systematic, making it quite easy to conduct. However, as with anything, there are also challenges. These include time constraints during the data analysis, potential complexity of the design, and disagreements of the findings. For the study, a chart audit will be conducted using participant information, as I said before, fluid balance charts, weight statistics, and the doctor's medical rounds, impression and examination. The study will be conducted at Logan Hospital in wards 3C, which is a combined cardiology and medical ward, and the coronary care unit, which is a joined ward as well. They're sort of considered one ward but two separate areas, which is located in Brisbane and Queensland. Purposive sampling will be used to specifically target research participants who fit the inclusion criteria. The sample size of 74 participants will be used, as this will provide a sufficient amount of data needed to gain valuable information without developing false results. The sample size has also been chosen because Travis' study had 34 participants, and they suggested that more study needed to be done in this area but with a larger group. The sample size has also been determined by Rheosoft sample size calculator. So the population size of congestive cardiac failure patients that are admitted to Logan Hospital is roughly about 100 patients, sort of per month, per 2 months. Margin of error is 5%, confidence level of 90%, a response distribution of 50%, and the following equation was used to determine the sample size. So n equals nx divided by n minus 1 e squared plus x, therefore giving me a sample size of 74 participants. My participants will be recruited within the wards 3C and the CCU, which are the only ward in the hospital which has implemented the fluid restriction jugs. The participants will be included if they are older than 18 years old and have a history of congestive cardiac failure or have an ejection fraction of less than 40%. Informed consent will be sought from all participants in the study regarding their hospital records. The objectives and aims of the studies will be explained to all participants, and specifically the benefits and risks will be highlighted. Participants will have the right to refuse to be included in the study, and they will also be informed that if they choose to do so and refuse, it will have no effect on the study or the outcomes. Here is an example of participant information that will be collected and assessed for the purpose of the study. So when the patient comes in, we usually do a base weight, and the next day we will usually do, in a 24-hour period, calculate the total input, which is 1625 mil, for example, a fluid output of 2040 mils, calculate the difference, which for this person was about 415 mils, the weight for that morning. So we usually do our weights in the morning before breakfast but after they've urinated for the morning, and then see what the doctor's impression is, so whether they're fluid overloaded. The dry weight also is usually calculated by a GP at home, which is their base weight without any fluid at all. So that's not the actual weight when they are admitted to hospital. And then the following day, same thing, input, output, the difference, and the weight, and the doctor's impression, and then so on and so forth until the patient is discharged. Ethics approval will be sought from the nurse unit manager of the ward in which the study will be conducted, Queensland Health Hospital Ethics and Research Committee, James Cook University, and then the National Health and Medical Research Council. There is no perceived risk associated with this study, as there will be no participant contact other than gaining consent for use of their medical records. This is considered to be a low risk according to the National Health and Medical Research Council. Privacy, confidentiality, anonymity, and non-maleficence will be maintained throughout the study in accordance with the NHMRC guidelines, as participant information will not be named, and the information gained will be recognised as participant 1, 2, 3, etc. The timeline, I plan on starting this research in 2014. In January, I will hopefully be finalising my ethics approval. From February to June, I'll be recruiting participants and beginning the research process, as not all 100 patients or 74 patients come in the one go. It's usually sort of 2 to 3 patients a day, so there'll be a running record and a running recruitment process and research process. In July, I'll be analysing the findings. August, be writing the journal article and reflecting on the research that's been collected. And then by September in 2014, I'll be submitting a journal article for publishing. The budget for this research proposal, the study will be cost effective because there is no need to hire any assistants to help with the data collection or the analysis, as a researcher will be solely responsible for the conduct and evaluation of the project. No travel costs will be involved, as the researcher works in the chosen hospital. The only costs that should be involved in this study will be stationary materials to record the patient's information from the medical charts, and this cost will be approximately $200. The dissemination plan. A report will be done up on the results of the study for the nurse unit manager of the ward in which this study was carried out. And a presentation will be organised for the nursing staff on this ward to present a summary of the study's findings, which I know they will be extremely interested in. A seminar presentation at local hospitals may also be an option if the study findings show that fluid restriction jugs are beneficial for the participants, so we can start implementing these jugs into other hospitals and then eventually into the community. And then finally, a formal research report will also be submitted for publication into the Australian Journal of Advanced Nursing Practice and possibly other journal articles. That is all. Thank you very much for listening to my proposal, and I hope you will consider this a worthy research article to do. Thank you.